a little bit more. But suffice it to say, there is a lot of misinformation out there about heat stroke. And it's something that I've become very passionate about in my career, actually, even before I really got into wilderness medicine, because when I first became an EMT, I've been a provider for about 20 years and about 12 of those as a paramedic and the preceding 8 as an EMT. And I went through a great EMT class, had great instructors. We learned, good information. But a lot of it was kind of the textbook standard curriculum kind of stuff. And I got taught how to treat heat stroke or how to recognize heat stroke out of that textbook. And then I had my first actual heat stroke patient, and it was not at all like it had been presented to me. And the treatments that we were taught to use didn't work. And it really stuck with me because it was a tragedy. I mean, this person could have been saved. And what we were doing for him was just the wrong thing. And a lot of that wrongness persists. It pops up all the time in curricula and in teaching points that come out this time of year. So I've just gotten kind of burnt up about it, to be honest with you. So let's get into it and talk about what we really need to know. For the most part, there are 2 kinds of heat strokes. The first is the classic designation, and this is when you have basically just an inability to cool more rapidly or more effectively than you're kind of gaining heat or producing heat. And so the classic image of classic heat stroke is what you see on the left. Like a little old lady who lives in an apartment where she can't afford air conditioning and it's really hot outside and she doesn't have good ventilation, and the temperature, is building inside the apartment. She can't really cool herself effectively, probably for a combination of reasons, including physiological changes as we age, and she just gets really, really hot. And so, classic heat stroke is really just about not being able to cool or find coolness. And it can be really deadly. The image on the left came from a heat wave in Chicago back in about 1997, where they had dozens and dozens of deaths across the city of that kind of scenario that I just laid out for you. The other main category of heat stroke is exertional heat stroke. And this is the one that actually I'm a little bit more interested in just because of my involvement in wilderness medicine, where we do a lot of standby coverage for athletic events, and we have a lot of people who are exerting themselves while they recreate. So this is the one that I definitely see more often in my line of work. And as the name implies, it's really just about somebody who is really producing a lot of heat because they are raising their own metabolism, exercising, and kind of speaks for itself. There's some other forms of heat stroke associated with other kinds of increases in that metabolic rate. So anything involving a whole lot of like a catecholamine surge or stimulants or things like that. So you can see heat stroke with excited delirium patients, certain forms of drug abuse. But this talk is really mostly about the classic and exertional heat stroke. So this is actually a really serious epidemiological problem. Depending on the data source that you're looking at, there are as many as 10,000 deaths a year. Some of the data is a little bit old. So the 10,000 deaths a year figure is probably about 6 or 7 years old at this point. But we have reason to believe that it's about this many deaths a year, which is surprisingly high. And there's a very close association with football, especially football training in the summertime, when athletes are coming out of dormancy, I guess, and they're getting back into their training groove, and they got all the pads on and they're practicing in July and August in really high heat. Very, very close association with football practice. And you can see the mortality figures are pretty sobering. So look at that 2-year mortality rate at 71%. The reason for that is that heat stroke causes a lot of damage even if you survive it. It causes a lot of end organ dysfunction, especially kidney impairment. It can cause clotting disorders. There can be some really profound changes throughout the body, even for people who do survive heat stroke. And so ultimately, it can still sneak up on you and essentially kill you months or years later. It can certainly cause a lot of neurological damage. because the brain does not like being hot. And one of the things to understand is that a lot of the risk factors that you may be familiar with from your initial introduction to heat stroke, probably in like your initial curricula, as far as certain medications like SSRIs and medications that increase that underlying metabolic rate, people who are overweight, dehydrating types of substances, all of those underlying risk factors, those are risk factors, but 50% of patients who succumb to heat stroke actually have no underlying risk factors at all. So all it really takes is for you to get too hot and not be able to really do anything about it, and you might catch yourself a case of heat stroke. So I actually have a friend who suffered heat stroke. He's a firefighter for a large department here in Kentucky, and we went through recruit school together. At the last fire department that I worked for, and he moved on to greener pastures. And so, we'd kind of kept up with each other, but not really like super, super close friends. And so like I was kind of bewildered that one day his wife put up this Facebook status. And apparently what happened is that he was fighting a fire, hot day, turnout gear, all that kind of stuff. And he started feeling kind of unwell, and was transported to the hospital actually with a kind of a field diagnosis of heat exhaustion. Big difference between heat exhaustion and heat stroke, which we will break down shortly. But it ended up that he actually was suffering from heat stroke, and you can kind of see what happened to him. Now, this post was just 2 months after this initial incident, and you can see that he basically had lost the ability to conduct like activities of daily living. Had to relearn everything from walking to writing, all kinds of problems. And, she's continued to update all of his friends on this since it happened. And it was a pretty slow recovery. He's back to work now. But unfortunately, not to be too morbid, but keep in mind that 2-year fatality rate, even amongst people who survive. So this is somebody who has suffered a very serious illness, and there may be long-term effects of that, even though he seems to be on the upswing right now. So it's a big deal, and something that we need to be able to recognize and then treat really, really aggressively. So I hate this picture more than pretty much anything in my life. There are so many terrible and awful things going on in the world right now, and I am not involved with most of them. But I see this picture all the time, and I have decided that it is probably the biggest problem facing humanity. Again, just through my lens in my life, and I am the star of my own play, and so this is the worst thing. And I see this picture pop up all the time, all over the place. And you've probably seen it too. In fact, if you Google heat stroke and do an image search, you're going to see a representation of this guy all over the internet. I call him Orange Man. And we actually did an entire episode of our podcast called Orange Man Must Die, which has been misinterpreted in a political frame over the last couple of years. And so I do feel compelled to point out that it has nothing to do with Donald Trump, and I don't know why anybody would think that a wilderness medicine podcast would have anything to do with him. So when we talk about Orange Man, we're talking about this guy, and I'm not just trying to be goofy. That actually people send us messages along those lines in our Facebook page inbox. All right, so Orange Man refers to this heat graphic. All right, and this was originally produced by the National Weather Service in Sacramento, California, the Sacramento field office. And I guess it just went viral and took off. If we look at the heat exhaustion side, it's actually pretty reasonable. It's pretty accurate. These are the classic symptoms of heat exhaustion. And I actually think that heat exhaustion is extremely common, maybe even ubiquitous. I know I've suffered from heat exhaustion. I think most people have, whether you're working out or you're working your yard or you're fighting fire or whatever it is, where, you just get a little bit too hot. And you are, just not feeling good. And so what do? You stop working, you stop exerting, you seek shade, you seek some cool fluids, you try to get in front of a fan. basically just logical things that most organisms, know what to do or instinctively do when they get too hot. When my dog comes in from a walk and he's a little furry lap dog and he's getting a little bit old and he gets hot easily, he goes straight to the floor vents in our house and just lays on top of them. Right. So heat exhaustion is like very, very common. Even if you're not approaching true heat exhaustion, just general heat stress, certainly very common. And kind of everybody knows, I think, what that looks like and what to do about it. But on the heat stroke side, we got major problems in this graphic, and I think that they're problems that are so significant that they may cause people to fail to identify this very life-threatening condition and fail to treat it appropriately. All right, so the first thing is no sweating. This is a myth. It is absolutely not true that if you are suffering heat stroke, you stop sweating. It is completely unhelpful to even consider the presence or absence of sweat on the skin in identifying heat stroke. The literature is very clear that about 50% of heat stroke patients will continue to sweat. So it is true that some heat stroke patients stop sweating. I guess maybe I phrased the myth a little bit inaccurately. Some heat stroke patients do stop sweating. It's more associated with classic heat stroke, where a patient kind of more or less gradually gets hotter and hotter and hotter and hotter, and their compensatory mechanisms start failing. So it's if anything, it's associated with classic heat stroke, but even 50% of those patients will still keep sweating. And if you think about it, what are the conditions in which somebody is susceptible to heat stroke? Well, often it's resulting from high humidity where sweating is ineffective. So many times a patient may have stopped sweating, but the sweat is still clinging to their skin and soaking their clothing because it can't really evaporate effectively. So you wouldn't even really be able to tell kind of what's like old sweat versus current sweating. It's just not something that we should be teaching, not something we should be looking at. All right, you see it again here, red, hot, dry skin. I mean, maybe sometimes yes, maybe sometimes no. I also don't love the body temperature because it's not clear whether we're talking about like an oral temperature or a core temp. And when it comes to thermal illnesses, hot or cold, core temp is really all that matters, right? Axillary temperatures and forehead temperatures and oral temperatures, they are useless and not appropriate for clinical diagnosis of heat stroke. So down here, we have may lose consciousness, and we have a very generic instruction to like do something after you call 911. Well, the may lose consciousness is, in my mind, a little bit too black or white. There's a whole range of neurologic dysfunction that can occur with heat stroke. It can be as subtle as a shuffled gait and agitation, or it can be as obvious as somebody who's totally unresponsive. So I don't love that teaching point either. And then, okay, call 911, take immediate action to cool the person. But what does that mean? What immediate action should we take? This is a big question because not all actions are actually going to be very helpful. So here is the actual diagnostic definition of heat stroke. It's when you have a core temp basically equal or above 104 Fahrenheit with CNS dysfunction. Now, there's a little bit of controversy in the wellness and sports medicine community about that 104 number. Really, somebody can actually be suffering from heat stroke with lower core temps, and it's actually the CNS dysfunction that's actually the more important component of that. So, you could have heat stroke at a core temp of about 102 if that CNS dysfunction is present. But for the most part, most of the definitions and treatment algorithms and most of the literature really kind of revolve around that 104 Fahrenheit mark. So it's a good one to be thinking about. All right, so let's just do a couple of quick examples here. We have a 35-year-old male construction worker. He's working outside a 90-degree day. He presents with slurred speech. His only past medical history that you can collect is a little bit of high blood pressure, and he looks like this. Could it be heat stroke? Yes. The sweating is irrelevant. How about this one? 28-year-old male running a marathon, 76. not too hot, not too uncomfortable. He has a temporary loss of consciousness, which he quickly rebounds from. But upon your arrival, he is agitated and he looks like this. Still could be heat stroke. Could absolutely, definitely be heat stroke. Last one, 28-year-old female hiking on a day a lot like today here in Richmond, Kentucky, about 80 degrees. She starts presenting with seizures along the trail, and she looks like this. Definitely, absolutely could be heat stroke. And you really need to start your differential diagnosis from that process, because heat stroke can kill you quick. I would argue that it will kill you a lot quicker than any of the other possibilities, quicker than hypoglycemia, quicker than hyponatremia, probably quicker than something like a head injury or even hypovolemia from trauma, something along those lines. We generally, if we have a patient who is hot and bothered, they're in a hot environment and they ain't acting right, we want to basically assume heat stroke, begin treatment for that, and then proceed down the differential pathway. So on our podcast, we came up with this graphic, which we spent a lot of time arguing about amongst the little subject matter group down at the bottom here. So this is a collaboration of myself and then my co-host Seth Collins-Hawkins, who is a emergency medicine physician in North Carolina and a medical director for all kinds of different wilderness organizations. He's actually the medical advisor for REI Stores and Outward Bound program and a bunch of other places like that. And then Todd Schimmelfennig is the curriculum director for Knowles Wilderness Medicine, who you might be familiar with as kind of like the AHA of wilderness medicine teaching. They're kind of the real powerhouse in that curricula space. And then Timmy D 4321, that is Tim Durkin. And he's a sports medicine and emergency medicine physician in Colorado with a lot of experience in search and rescue and a real expertise in heat illness. So we put our heads together and we came up with this graphic. And a couple of things to point out about this are that on the right-hand side, I stacked up the signs and symptoms like that just for visual balance, because I also had to fit loss of consciousness under that guy's occipital area. So these don't necessarily present in this order. You can see any of these, you can see none of these. You can have a patient who is initially unconscious. And like I said, the neurological symptoms can actually be very, very subtle. So just keep that in mind. These are kind of exemplars and not exhaustive. And we tried to stress that altered mental status really, almost in layperson terms, because lay people may not necessarily understand what neurological dysfunction means or stuff like that. So we kind of agreed on altered mental status, and that's really the cardinal sign of heat stroke. It's not the sweating. It's not even really the precise body temperature. It's altered mental status when somebody's in a super, kind of hot environment or is producing too much heat. So then we specify that what you really need to do after you call 911 is initiate cold water immersion. Right? Cold water immersion, or CWI, is the gold standard treatment for heat stroke. It's what is going to happen to an athlete if their athletic trainers are prepared. You will find at most athletic events these days cooling tanks to immerse a patient in cold water. And it's actually what you'll find at a lot of hospitals as well. Not every hospital has that capability, but a lot of major medical centers will have some form of a dunk tank or cooling tank or something to be able to work with to cool these patients. So cold water immersion is the standard of care, but what does that really mean? Well, there's a little bit more to it than maybe what the word implies. So I'm going to approach this kind of from a field treatment standpoint, because I'm a paramedic and we work in the field. So what you will need is something like this. This is a 100-gallon stock tank. You need some sort of a container that is big enough to not only put a person in, basically in water up to their chin, but obviously has enough room for the displacement of the water that person will produce. So about 100 gallons, no less than about 75 gallons is what's recommended. And this is exactly what I set up when my little company, Red Med LLC, when we do standbys for trail races and stuff. A bunch of these come out of my pickup truck, and then we make a run to the local convenience store for a bunch of ice and a ton of water, and we fill these things up. Right, so you'll need water, right? Now, as we go through all these things, think about where you could get some of these supplies if you were working in the field and you encountered a heat stroke patient. Um, could it be a garden hose from the residence or nearby residence? Could it be a fire hose? Do you need to call a fire truck to the scene? Let's think about where we can get water from. You will, to do this right, really need a bunch of ice. Use a whole lot of ice. Got to really fill up this water and make it true ice water. Tons of ice. Ideally, you have one of these, which is a waterproof thermistor, not technically a thermometer, although the difference is unimportant. And it has a big, long probe on it. And again, we need a core temp. So you're going to want some of this because we're going to be doing butt stuff. And this probe has to go rectally. And this nice long lead on the temperature probe allows you to do continuous temperature monitoring even while the patient is in the cold water immersion vehicle, if you will. It's also really helpful to have something like this, kind of a foldable, flexible stretcher. The mesh ones that are popular in the tactical environment are ideal because you can get the patient onto this, just pick them up and put them in the cold water tank. And the mesh obviously works really well in that water environment. But any sort of litter is probably fine. This is actually a place where backboards can still be handy because you can put the patient, lift it up, kind of tilt the backboard up over the edge of that tank, and the patient will slide off into that tank pretty easily once you release the straps. So you're going to need something like this to lift them up. And if you don't have a litter like this, I'd really encourage you to practice, lifting dead weight. And I know that most paramedics and EMTs have a lot of experience with that, but not everybody actually does. Some people are very, very reliant on different lifting and moving tools and so forth, and log rolling to get patients up. And if you just put sort of like dead weight in front of them and say, hey, get this patient up off the ground into this tub, it becomes a real Three Stooges routine pretty quickly. It takes practice and good body mechanics to lift somebody up off the ground. So things that require a little bit of practice before you just go into them. So remember our friend Nellie from the previous slide, his famous advice, it's getting hot in her, go take off all your clothes. We need to get these patients trauma naked. We want as much surface contact with the water in that cooling tank against the patient's skin as possible. All right, so here's what this whole setup looks like. This guy is not really naked, I think, for the purposes of just internet photo publication, but he should be naked. Cut all those clothes off, and then you're actually going to use those clothes as part of the cooling. You can see that they took his shirt and they've kind of pulled up over his head. We want to soak those clothes that we cut off in the ice water and then drape them over the patient's head to make sure we're cooling that as well. All right, so here's the basic steps. Right. First of all, number one, don't forget to just check your vitals and your level of consciousness. Although I think what I said is true, that we want to kind of assume heat stroke in these presentations and then do a differential from there. We don't want to forget about things like, cardiac arrest and other things of that nature. Somebody who maybe does have a more immediate threat to life, like an airway problem. So just make sure that you're doing your good basic patient care and get your baseline sense of what's going on with this patient's ABCs. All right, then we're going to actually insert the probe pretty much as one of the first things we do, or if you just have a simple rectal temperature thermometer, then go ahead and take that rectal temperature right then and there so that you can start to arrive at that diagnosis of heat stroke, and then also have a baseline for how long we need to be cooling. Get the patient up off the ground using whatever techniques you're using, and immerse them and then cover their head in ice water soaked clothing or towels. And then we need to stir. So just take your arm and stick it in the water and really work it around. We need currents to move heat away from the skin and bring cooler water back to the body. So it's not going to be as effective to have the patient just sit there immersed. We need to really stir it. Go ahead and make a little heat stroke stew and just keep on stirring. Now, the real goal here, if we're being technical, is to cool this patient to 102 degrees Fahrenheit, core temp. That's why we need to have that probe in early and then leave it in for the duration of this. Now, if you don't have that ability to monitor them continuously, we can cool empirically. So although we'd love to have a core temp, we can also cool to the point that the patient's mental status returns. There's pretty good literature that says that that's a pretty decent proxy for core body temp. But this is a process that is going to take a little while. It can take about 30 minutes, sometimes even longer. And that's assuming that your water is super cold to begin with. So this is a treat in place kind of a situation. And even if you're not using a stock tank like this, if you're doing something that's a little bit more field expedient, like you're dragging your patient into a swimming pool or a body of water, which I've done before in the gorge, I've dragged patients into creeks to cool them down. We're going to stay there for a while. We need to let that water kind of do its job and cool the patient. Interrupting cooling really is like interrupting CPR and cardiac arrest. The cooling is what is saving their life. So we all know how damaging it is if we interrupt CPR. And we all know now that the priority is high quality chest compressions. And we don't want to, interrupt high quality compressions for the sake of transport. The same exact thing is true with heat stroke cooling. The caveat here, a little bit like with CPR, is if the cooling is effective, right? So in other words, if my patient's in a stock tank and I have ice water and I'm stirring and I'm doing everything right, that's what I want to do. I do not want to pull that patient out of that water and put them on an ambulance or put them on a helicopter until we see core temp come down or mental status return. But if your cooling is not effective, if you're just, like trying to fan this person with a magazine or something like that because you don't have any other option, in that case, yeah, we need to actually get them to a hospital ASAP so that we can do proper cooling. So as long as your cooling is effective, we do not want to interrupt it. It's a stay in place situation. So here's why that statement is true. If we can bring that core temp down to 102 Fahrenheit or less within 30 minutes of the patient's collapse, their fatality rate is 0. Across the board, 0. Not like 0 immediately, but they're still going to die in 2 years. It's 0, right? 100% of heat stroke patients will live until something else kills them if we can get their core temp down to 102 within 30 minutes. That is the goal. That's the standard. That's what we're trying to do. So when we look at these different methods of cooling that are out there, we can see that some are extremely effective and some are not so effective. So the cold water immersion is the most effective, but it kind of assumes that the water is cold to begin with. You can see over on the left-hand side, if we start with water that is about 37 degrees Fahrenheit, this is absolutely the absolute quickest way to cool. So that's why athletic trainers and other people like that will have these tanks set up ready to go, all iced down and everything. Now, the next most effective method is actually something called Tarp assisted cooling, which we will look at an example of here in just a couple of slides. Very effective. And this is what I actually recommend that EMS crews learn how to do because it can be done in the field. So we have Tarp assisted. If you come down and look at the cold shower, fairly effective, but not as effective as you would think. And that's because when you're in a shower, you're not getting immersed. You have streams of water running over you. It's certainly, better than nothing or better than just fanning, but it's actually not as good as you might think. So in the field, think of this in terms of maybe something like hosing somebody down with a fire hose or garden hose or something. If that's my best option, then that's probably what I'll do, but it's not amazing. Fans, not that helpful. If you introduce a little bit of misting of water in conjunction with a fan, It makes it more effective, but in general, fans are not super effective for dealing with heat stroke. And then ice packs, not that helpful, not that effective. Um, certainly if you don't do any cooling, the patient's pretty much going to die. So something's better than nothing. But ice packs, which is one of the most common teaching points, right? Like pack ice packs under the armpits and the groin and everything, it really just doesn't work that well. So this is tarp assisted cooling. They've basically just made a bathtub out of a tarp, rolled it up. And you can see, though, that it's still ice water. And that is pretty important. So here's what I kind of advocate. When I was a firefighter, whenever the weather started getting warm, we would make sure that we had a cooler of ice water on the fire engine. Sometimes we had multiple coolers. And when you have multiple fire trucks on scene, you have multiple coolers of ice water. And it was part of the truck check. We did every day. Every station had an ice machine in the bay. And if you've been a firefighter, you know exactly what I'm talking about. We should probably start doing something like that in EMS. If you work in a fire-based EMS system, that cooler or multiple coolers for multiple apparatus could be the source of the ice water for this tarp-assisted cooling. But in EMS, we'd probably be very well served to figure out how to put some coolers on our ambulances for various reasons. And there's a couple of other good ones that we'll talk about shortly. But this is what tarp-assisted cooling fundamentally looks like. Very similar to the standard cold water immersion, but something you can actually do in the field. And it's pretty effective. Now, this is a picture from Austin Travis County. They had a call last year where somebody was in a heat illness in the shopping center area. They found a shopping cart, they found a tarp, they ran into a nearby restaurant, and they said, hey, we need all the ice you can give us. And they started to fill the shopping cart up. Apparently, the patient had a pretty successful outcome, but just keep in mind that if all you do is like take a shopping cart like this, fill it with ice, and then you try to put a patient in it, it's not going to be that effective. The patient will be laying on top of the ice. So you need to put the patient like in this first and then pour the ice all around them. But then again, you're not getting amazing surface area contact with just the ice cubes. The water becomes really, really key. So if you can figure out a way to dump a bunch of water in here, then, do what you need to do. But I think this is a great example of, this is a modern EMS system, probably one of the best in the country. There's no shortage of medical centers and hospitals in Austin, Texas. But they said, no, we are not just going to load and go. We're going to stay put. We're going to start cooling this person doing a cold water immersion style technique. Here's a body bag. You can put a patient in a body bag, you can fill it with ice water, and you can start doing a kind of a hybrid TARP-assisted actual CWI protocol using this. And this is actually what PHI medical helicopters, at least in Kentucky, have in their protocols for transporting a heat stroke patient. They will zip you up in an icy tomb, minus your head, of course, and transport you that way to contain all the water, which is a pretty good idea. So this is a picture my friend Seth Collins Hawkins, my co-host, sent me, a heat stroke patient from his facility. They are a very small, basically critical access hospital is where he works, which is his jam. And they don't have cold water tanks and a bunch of other stuff. So what they did is basically just took blankets, soaked them in ice water that they procured from the cafeteria. They're covering this guy in ice water. They're incorporating fans. They also have some other things going on. I think they did a cold water lavage rectal with this patient. And so they were doing what they could do with their facilities and supplies. But I just kind of wanted to show you a picture of what this looks like, because you'll probably see this a lot in hospitals as far as the draping with cold blankets and so forth. But admittedly, it's just not super effective. So it was the best that they could do, but it's not actually the right way to do it, which he would readily admit to. Now, here's an interesting product that we actually have in our supplies on Red Star, which is the Wilderness EMS team that I coordinate in the Red River Gorge, and that Walt is the medical director for. This is a product from North American Rescue. And it's basically a blanket version of a chemical cold pack. It's impregnated with this material that retains cold really, really well. The packets themselves are about the size of like a box of Pop-Tarts in terms of like overall dimensions, but a little bit thinner. And you have to pre-cool these. So you keep them in a cooler, you keep them iced down, and you need multiple packs because you actually rotate them out as the first one that you drape on the patient starts to basically warm up. The idea is that you would put it back in the cooler to cool down again and then put a fresh one on. So what we would do on Red Star is if we got a call that somebody was unresponsive or not acting right or something like that along the trail this time of year, we would now at this point we'd pull these basically from the freezer down at Powell County EMS and go ahead and hike them in an insulated pouch. We have these like insulated Nalgene pouches that basically attach to the outside of our bags. When I'm doing my event standbys with RedMed, I have a cooler of ice water in my truck, and I have a bunch of these floating in there. And, you know, they're not, again, like they're not as effective as cold water immersion, but if it's the best that you can do in a truly austere environment, you know, you're a couple of miles down a trail, then at the very least, we could put these over the patient. We could get them packaged and we could start to carry them out towards definitive care while doing some form of cooling. So this could be something that is carried on an ambulance as well in that cooler of ice water, which I advocate we start adding to the rigs. Now, these guys here are not that helpful. IV fluids don't have a big role in treating heat stroke, especially in the field. If you're in a hospital environment where the ice water has been the Freudian slip there, where the IV fluid has been pre-chilled, then they can certainly be a part of the mix. I mean, there's no reason not to start an IV and give some cold IV fluids. But in the field where we really don't have like cold IV fluids, unless you were keeping IV fluids in a cooler, they're not going to do really that much of anything. And many patients are actually, heat stroke patients are actually euvolemic. They are not necessarily dehydrated. Now, again, no reason not to do this. It's just not going to be my first line. So do the aggressive cooling, do the cold water immersion, do the other things we've talked about. Then you can start a line and put some fluids in. It's not going to hurt. It may even help with some of the kidney function issues. But if anything, these are adjunctive. That's the point. And I hear a lot of EMS providers when we do training and stuff like that at my agency, you know, they always go to, okay, I'm going to start a line. I'm going to start fluids. It just doesn't really make that big of a difference for the heat stroke patient in the field. And these chemical cold packs are kind of the same way. They just don't get that cold. So they're not that helpful. Again, if you want to add them on, pack them into different parts of the body, kind of in addition to some of these other things, by all means, but they are not the first line treatment for heat stroke. So let's talk about packing and where we should put cold packs and so forth. What's the standard teaching that you see in most textbooks? It basically looks something like this: in the axilla, the groin, and behind the neck. As it turns out, that is almost completely ineffective. What we really should be doing is putting them on the palms, the soles of the feet, and the cheeks. These are areas where there is extraordinary blood flow. And if you take a look at some of these gnarly body plasticized blood vessel exhibits that travel around and stuff, you can see exactly why. A lot of blood flow going through these surfaces, the palms, the soles of the feet, and the cheeks. Ton of blood volume comes through, and the skin is thin. And so it's actually much more effective in cooling if we place our cold packs or ice packs on those surfaces. And it's about 2 times as effective as putting them in the axilla and the groin and behind the neck. And ice bags are actually way better than chemical cold packs. So an actual bag of ice is way, way better. That chemical cold pack loses its cool pretty quickly, but with a bag of ice, even as the water melts, it still maintains a lot of its chill because the remaining ice cubes keep that water cold. So ice bags rather than ice packs is another big takeaway from this. So to sum this all up, here's our heat stroke graphic. You can download this from the Raw Medicine website if you want to join our campaign to post it every time you see Orange Man on Facebook. I see my friend Glenn Keating joined this Zoom a little while ago, and he's one of my allies in tagging me whenever he sees this pop up. Whenever he sees Orange Man pop up on Facebook, people will tag me so that I can come along and post the graphic so that we can try to banish Orange Man from public distribution and put something a little bit more evidence-based in place. The last thing I want to add, because it comes up a lot, is about shivering. It's another misunderstanding that we don't want the patient to start shivering during the cooling process, and if they are shivering, we're being too aggressive and we should stop. That is not true. The shivering does not produce enough heat to reverse our larger cooling. So very, very popular teaching point that's out there as well is, don't let them start shivering. You can forget about that. The shivering is inconsequential. We want to cool these patients as aggressively and as quickly as possible. And there oftentimes will be shivering that results from that, and that is perfectly fine as long as their body temperature, their core temp, is less than about 102 and they don't have neurological dysfunction. So that concludes my presentation on heat stroke, and I'm happy to take any questions. And I see some in the comments here, so let me kind of go through these one by one here. Somebody asked if they can use the title Orange Man Must Die. Please feel free. And then we have here, if I'm hearing you right, CWI is a standard. Therefore, you should be teaching this. There should be a stay-in-place situation. That is correct. That is exactly what I'm advocating. Jacob has said we just included the body bag CWI into our protocols. That's amazing. That's a great way of doing it. And if there's any more questions people want to launch my way verbally, I'm happy to take them.
Oh, I have so many questions. So one question here. You mentioned their goal temperature. You said it's 102. Well, why not just like get them back down to normal temperature? Because 102 is still a fever. Like that's still pretty hot. What's the deal?
Yeah, so 102 could be basically a trigger point for doing something else or doing the next thing, right? So if you had to make some choices about prioritizing care, do we get them in this cold water immersion tank, which is going to interfere with many aspects of care otherwise, or do we do X, Y, and Z first? Well, what you could say is let's cool them, let's get them out of the danger zone down to 102 degrees, and then we can look at doing some other things. Or potentially that could be your trigger point for transport from the scene. So if you were able to do that continuous temperature monitoring and you could verify that we'd gotten less than 102, okay, now let's go ahead and load them up for transport. And we could maybe at that point switch to some of those other forms of cooling that are more amenable to transport, like the draping and the fanning and the ice packs and that kind of stuff.
Fantastic. It looks like there was a question on there. Are you worried about damage from direct contact with the legs? Like I guess the ice on the legs, are you giving somebody frostbite or thermal damage?
Yeah, for sure. You always want to be concerned about local tissue injuries with cold packs and hot packs. So the standard kinds of approaches would apply. Wrap your cold packs, your ice bags in like a single wrap of gauze or a cravat or something like that, just a thin barrier, just to keep it right off of the skin, not right on the skin, so you don't have that local tissue injury. The bags of ice are way less risky for local cold injuries than the chemical cold packs are. So that's a big problem with the chemical packs, both of the hot and cold variety. They can produce like kind of a super amount of thermal energy right there locally, but it's not very effective kind of in a broader sense. So the athletic trainers a lot of times will just put the ice bags just right on the skin and not really worry about it too much. But it's never a bad idea to put a very, very thin, gauze type layer just between the source of the cold and the skin.
Yeah, and if you actually, if you think about it in the amount of time from a physics standpoint, just like making ice cream, you're never going to get it, as long as there's ice and water, you're never going to get it under 32 degrees.
Mm-hmm.
So you can't actually freeze until that whole phase change takes place with water. But with a chemical, like you said, if it's down to 20 degrees, then you could easily get it 20 degrees.
Yeah.
Oh, should I be giving these people Tylenol? I give everybody Tylenol for fever.
No, nope. Tylenol is not helpful. This is not a pyretic process, right? So the things that Tylenol acts on as an antipyretic are not happening in the patient. This is about dissipating heat. This is about allowing a thermal gradient to be created where the heat moves out of the body. So, I can load you up with Tylenol. I can give you IV Tylenol, but that doesn't move that heat out of your body. So, Tylenol can be helpful in, combating some of the hormones that basically produce fever, but it doesn't have a role in heat stroke.
Fantastic. David, thank you so much. Fantastic presentation. And from everybody at EMS Grand Rounds, we certainly appreciate it.